Excellent. Thanks, everyone. It's nice to be here. I appreciate your invitation. So, a lot of times when I do these talks, it's like let's start at the beginning. I mean, why do we do transplant for these kinds of disorders? And so the first transplant was done for a lysosomal disease was done in 1978 in a patient in Bristol in the UK. And actually the rationale for that goes back to 1968, where Liz Neufeld's group had cells in culture with a lysosomal disorder. Those were Hurler and Hunter cells, but they accumulate substrate. And then the story goes that someone inadvertently put normal cells on top of the tissue culture where these cells from the Hurler and Hunter patients existed. And to their credit, they learned that these cells, the normal cells, help alleviate the accumulation of substrate in the lysosome. So they called that cross correction, and that was really the rationale for considering transplant for the lysosomal disorders. So essentially the idea is if you have normal cells, hematopoietic cells that you can establish in a patient, those cells are going to circulate through the body for the rest of the life of the patient and serve as a source of enzyme and potentially treat those cells. So again, that goes back to the 80s when we started doing transplants. For it was a little before my time, but not that much. And so a lot of these patients with lysosomal disorders, including MLD, were treated at that point. But obviously all the genes got identified and cloned, and you can make pharmaceutical grade enzyme. And so, why not just treat the patients with enzyme? And a lot of the lysosomal disorders are just treated with enzyme, but the patients that have neurologic disease, where enzyme is thought not to penetrate into the central nervous system very well based on the blood-brain barrier, the thought was that maybe there's still a role for transplant, and indeed we're still using transplant in this situation. So the idea is that some of the cells that are donor-derived are going to make their way into the brain parenchyma after transplant and serve as a source of enzyme. So it's primarily the microglial cells we think are the ones that do this. And I think, as Allison kind of mentioned earlier, it's a very small proportion of cells that actually make their way into the brain. So the microglial population is 10, 15% of the brain. And ultimately, at the end of the day, you may get 1 or 2% of the cells within the brain that are donor derived. So it's not a very efficient process, but certainly for some of the diseases, there is some utility using transplant. So I'm going to jump right into MLD here. So this is data from our institution, went back several decades actually, and published the outcomes of these patients. And, it's very clear that transplant doesn't do what we would like it to be able to do for these patients. So a lot of these patients actually were not pre-symptomatic when we started treating them with transplant. And so that's part of it. And as you can see kind of on the left, that there's a fairly quick drop off in terms of survival. And a lot of these patients just progressed and died going through transplant. But, it's very clear transplant is not as safe as we would like it, and it's not as efficacious as we want it to be, and we need something better. So Allison was talking about in vivo AAV therapy. So essentially you're taking the AAV vector and delivering it intravenously, or in some circumstances in the cisterna magna, but you're injecting the vector into the patient. This is an ex vivo therapy. So, and by that I mean we have to isolate the patient's own stem cells instead of using somebody else's. There's a process we use called apheresis here. So most of the blood stem cells are within the bone marrow. You can loosen those cells up and get them into the blood by treating the patients with GCS, granulocyte colony stimulating factor, and Pliclixofor. So you can release those cells into the bloodstream. And then you have to have a catheter placed, and then the blood essentially goes out, circulates through the apheresis machine. The machine collects the cells that we want. The blood goes back into the patient. But this is actually one issue, because there's a lot of volume of the blood that's actually outside of the kid at any given time while you're doing the apheresis. And if you're, 60 or 70 kilos, it's not a huge big deal. But if you're 6 kilos, it's a much bigger deal. And so you need to have a patient big enough to be able to actually do this. So the kids have to be at least a few months old to be able to offer apheresis piece. But then, so in this circumstance, for MLD, the cells are shipped to Milan. That's where the treatment manufacturing site is. So we ship the cells fresh to Milan. They do the transductions with the lentiviral vector that's set up for this purpose. Those cells are then frozen down, and there's about a 6-week process by which the cells are tested and shown to be ready to be administered to the patient. So the family's at home during that span of time, then they come back. They still need to get chemotherapy because we have to eliminate the cell population that's not corrected so that we can infuse the manufactured cells, and then we can follow the patients and see how they're doing. So, and one of the things we can kind of come back to a little bit later is that it's an expensive process. I just wanted to show, so this is our bone marrow transplant protocol. And busulfan, fludarabine, cyclophosphamide are part of this. We use serotherapy, meaning anti-thymocyte globulin, which helps knock out the T cells, and rituximab that Joanne kind of referred to help knock out the B cells, and then the patients get their cells back. But it's pretty intensive, and the patients need to be on immune suppression while you're going through this so they don't reject the cells from the donor and they don't get graft versus host disease. So it's fairly complex. But this is what the prep looks like for the gene therapy for MLD. So it's just busulfan alone. Patients don't get neutropenic for about a week or even 10 days out after transplant. They get out of the hospital faster. They get home faster. So a lot less complications associated with the autologous, meaning you're getting your own cells back, versus the allogeneic transplant piece. So in terms of some of the data from Milan, because all the clinical trials for MLD were done in Milan, but this data is very straightforward. So they had a pretty robust natural history cohort that they compared the gene therapy to, and so this is survival without a lot of motor impairment. Whoops, I'm getting ahead of myself here. So those Kaplan-Meier curves are pretty straightforward. So, and this is the gross motor functional classification, which is a very straightforward thing to use in terms of how these patients are doing. And again, if you look at those things at 3 years and the patients that were treated with gene therapy versus those that were not, I mean, the data is pretty compelling. You can also look at cognitive function here, and this is probably a little bit harder to see, but most of the patients that were treated, so there's pre-symptomatic, late infantile patients, pre-symptomatic, early juvenile patients, which is in the middle, and then some early symptomatic, early juvenile patients. But it's kind of hard to appreciate, but the natural history patients are all at the bottom there, essentially. So, and this is looking at some of the outcomes in terms of the biochemistry of this. So the aryl sulfatase A activity in the cells is on the left side. So as you can see, that gray area is the normal range. And so not all of these patients, but a lot of the patients have supernormal levels of enzyme, which we think is important. We think there's a good chance to get better correction with higher levels of enzyme. So that's very encouraging. And then aryl sulfatase A levels in spinal fluid. So the guys in Milan are the only people that I'm aware of right now that are doing that testing. But again, a number of these patients have normal levels of ARSA in the CSF. So this was approved in 2000, and I think 5 years ago, in 2020 in the EU, and was just approved in March of 2024 here in the US. So these are the sites that are currently able to offer the Lenmeldi therapy, and I think there may be some more coming down the pike as well. One of the issues I wanted to kind of talk about here, though, and these slides are fairly sophisticated, mostly because I didn't do them. I kind of swiped them from the Orchard Therapeutics guys, but it helps to make the point. But one of the issues here, so I'm not going to really talk a lot about the insurance side, but that's a big issue. And I think that's going to be an important thing to talk about. Maybe we'll have a few minutes at the end of this or during the panel. But obviously we have to identify patients that we think are reasonable patients to treat. So that's kind of the first step. Then they have to come and go through the apheresis process. So the family's generally with us for about 2 weeks. They come in and have their evaluations done. They start the GCSF. They have the cell harvest done. And sometimes we have to do a couple days worth of harvest. Then again, they go home and there's about 6 weeks of this manufacturing and quality control process before we get the go ahead to bring the kids back to actually treat them. And they come back and have a brief outpatient evaluation, get admitted, get the chemotherapy, and then get their product. But then again, it takes another month or so for them to have enough cells present after the infusion of the corrected cells to actually potentially serve as a source of enzyme. So this whole process is fairly extensive and can take a number of months. So identifying these kids and getting them on track to get treated, especially the late infantile kids, is really key. So I just, in conclusion, so there's a couple of things. So we think about safety, we think about efficacy. Generally, I'd say it kind of depends on what kind of donor you've got and what the status of the kid is, but generally 10 or 15% peri-transplant mortality with allotransplant. It's not going to be zero with auto transplants, with the gene therapy. The kids are still going to get neutropenic, they're going to get thrombocytopenic, somebody's going to get an infection or a bleed or whatever. But it's probably order of magnitude safer, really, in terms of the early transplant pieces. In terms of efficacy, I mean, we can deliver potentially more enzyme with corrected gene therapy based cells than we can with allotransplant. So not necessarily all the kids are going to have supernormal ARSA levels, but certainly some of them do. We're interested in biomarkers. We had some discussion about that a little bit earlier, and there may be things that we can be following there too in terms of efficacy. We have to kind of figure out, I think, as a group, what parameters we're going to follow. We're going to have some meetings to talk about that. So in terms of patients treated in the US, we treated 5 kids on a single patient IND compassionate use basis before things were licensed. And then there was the first patient that was going to get licensed therapy, the cell product didn't meet specifications, and so we had to do that on a compassionate use basis too. So there's actually 6 that got compassionate use, and the last 3 have gotten licensed product. So we've done a couple of those, and Laura's group have a baby still not in the house anymore, right? Probably out now, but right. So anyway, so the total of 9 have been treated with MLD or the pre-licensed product before that. I want to just, again, mention a little bit about the insurance-related process here, because this is an expensive product. The hospital's concerned about Minnesota Medicaid patients because they only may get 20, 25 cents on the dollar. And if you got a $4 million cell product to pay for, they're nervous about that, kind of understandably. But we're obligated legally to treat patients that have MLD that would otherwise be, treated. So the hospital has to kind of suck it up essentially and just treat the patients. But if there's a patient outside of our Minnesota, the hospital isn't obligated to treat them. And so we have to go through a process, especially the out-of-state Medicaid patients. We have to go through a process of setting up single case agreements to be able to do this, and that can take months and is a major problem. So virtually everybody in our institution has to get, we're trying to do this with a patient right now, but everybody in the institution that's going to see the kid has to get credentialed by that state's Medicaid group. The hospital has to get credentialed, and then they have to set up some sort of agreement where the hospital isn't going to lose money. Otherwise, they're just going to say no. And so we're going to have to deal with this on a national sort of basis, because otherwise kids are going to get put at risk because they're going to get put off because we can't figure out the finances of how this is going to work. So we've been looking for a decent therapy for a long time. Now we have good licensed therapy, and now access is actually going to be, that's kind of what keeps me up at night now for these types of things.